Now, tonight's presentation. So Dr. Bismar is no stranger to Prostate Calgary. He's presented to us in the past. He's published more than 115 peer-reviewed publications in prostate cancer, biomarkers, and genomic signatures. So he's partnered with Dr. Eric Heidemann at the Prostate Cancer Center to investigate and characterize novel molecular signatures to be implemented in men with prostate cancer enrolled in the active surveillance program. And I know they've got a great setup at the Prostate Cancer Center for enrolling and looking after those gentlemen on active surveillance. The aim, of course, is to guide the urologists on how often to rebiopsy patients on active surveillance and when to implement definite therapies. Sort of looking to establish precision active surveillance. So he's going to be updating us on his latest research in that regard. So
thank you, Brad, for this nice introduction, and thank you all for inviting me again to speak. So today I'm mainly going to be focusing on some of the more advanced research that we were doing. Mostly, as Brad mentioned, we are focusing now in two programs, one actually involving active surveillance patients, or the second program is actually looking at high-grade tumors in patients with castrate-resistant post-hormonal therapy with neuroendocrine differentiation. But I will not mention that much on that subject as of now. But at the end, if anybody has any questions, feel free to ask me. So basically, I'm a pathologist. I practice at the Rockview Hospital. So I'm the one who usually look at the tissue samples of patients and diagnose whether the biopsy is positive for cancer or negative. And if it is positive, then I will grade the biopsy using the Gleason scoring system, as you may be all familiar with. And then also, as part of prognostication, clinically, we provide estimate of the tumor extent within each individual core. Then we give a summary at the end of the Gleason grade, how many cores are involved, the percent involvement, and now we incorporate also percent of a Gleason pattern 4 within these biopsies. If there is any evidence of tumor outside the prostate that we see, also a couple more morphological features, and all that is in the hope that we're able to guide the urologist into making a better decision for treatment for those patients. So active surveillance usually are targeting men with a low-grade prostate cancer, so mainly Gleason score 6, and potentially some of the 3+4 if there is a minimal 4. And with about 5 or 6 maximum biopsies positive and no more than 50% positivity usually. So the way we carry out these things are still not 100% reliable in terms of predicting which men would potentially progress and may need to go for active therapy, and which men could safely be still on active surveillance for longer time. So what I'm trying to do is to develop a molecular signatures by using genomic markers with either immunohistochemistry, which is assessing the protein expression of those genes, or we're actually looking at the gene expression, or looking at how many copies of each gene a tumor may have. And by knowing these genes being worse or good, we could potentially develop molecular signatures that we could implement either in tissue biopsies or in liquid biopsies, so a blood test or urine test. So the way I do it, usually I work from samples of prostate cancer. Then we will assess the gene expression levels of those genes. And then we investigate public data sets that are already published to look at those genes, understanding if they are up or down. And then we utilize the protein expression of those genes to try and develop at the end signatures to predict outcome. So obviously we start from resources to discovery. We use analysis, testing, and validation. So what we did so far is we actually developed a 10 gene signature that we validated in more than one cohort, from Mayo Clinic, from the Swedish cohort, from Memorial Sloan Kettering. And we showed that this signature is able to associate with disease progression in patients overall within these cohorts, but also in the group of men with prostate cancer with Gleason score 6 and 7. So they also show significant difference in terms of association with disease progression and lethal disease. So as I mentioned, we did validate this signature. The last publication that we have was based in a study from the Mayo Clinic. And clearly you can see that if we assess those 10 gene signatures in patients or in men with prostate cancer, if the sample have low expression of those 10 genes, they are at lower risk of developing biochemical recurrence and also metastasis versus high expression. And the hazard ratio, which would estimate over the control, like how many times a patient with a high signature could develop biochemical recurrence or metastasis, you can see it's about 4 times higher. And in the event of lethal disease is about 24 times higher. Again, this is just based on one publication, but we did assess this prior in another publications. And so what we did also in this cohort, because we're trying to see if the same signature could also predict disease progression in group potentially fitting active surveillance, which the majority of those patients would be a Gleason score 6 or 7. We also showed that the signature is still able to predict with a good separation between the low risk and the high risk for the biochemical recurrence and the metastasis. So now what we're trying to do is, because of the differences in the endpoint, which means when we developed the test, we were looking at the radical prostatectomy samples, and we were trying to predict if there would be a biochemical recurrence or there would be a metastasis or lethal event based on the signature. Now, for patients on active surveillance, the outcome may not be the same, which means we have to be able to see if the signature able to predict upfront whether the Gleason score 6 or 3+4 is going to progress within certain time limit. So what we are trying now to do is reanalyze the signature on another set of samples that we have. This set is 150 samples of patients who fit the criteria for active surveillance. So they patients, all of them had Gleason 3+3. They had 4 or less positive cores, no more than 50% per core. But because the samples were done prior to the establishment of actually active surveillance program in Calgary, so we have the radical prostatectomy data on those samples. So what we're trying to do now is take the stent gene signatures, assess it on the biopsy, and investigate, are we able to predict which of those biopsies is going to progress to higher grade, and looking at the radical prostatectomy, see if the signature will be able to tell us whether the cancer have gone outside of the prostate boundary or it's still limited to the prostate and with no adverse pathology events. And so also a critical point for us is to understand if you have a signature like that, since the patient usually have between 1 to 5 or 6 different biopsy samples at each time. If you have a signature, how are you actually gonna implement this? Are you supposed to measure one biopsy, or are you supposed to take maybe 2 or more, or take all the positive biopsies and look at the signature from all of those? Because of the level of the heterogeneity between the patient tumor samples, we need to understand that. So at least if we develop a signature, we can inform the urologist how they actually, or actually not inform the urologist, but we can understand when the urologist is going to ask us, can you assess the molecular signature? We can know which biopsy we should take, or we should take more than one, we should take only one. So actually we are doing this study with my colleague at UCLA in California. He's a bioinformatician. So we're looking now to understand how often the genomic background in those low-grade tumors are different between the different biopsies within the same patient, to enable us to tell how we're going to implement a signature, not necessarily this signature, but any signature in needle biopsies. So this is an article that we published in collaboration with GenomeDx Bioscience. It's a Canadian company. They develop, not sure if people would heard about it. So it's a molecular signature based on 22 gene. It's called Decipher Test. So this test has been published on before to predict biochemical recurrence, metastasis, lethal disease. We looked at it in terms of being able to predict adverse pathology in those patients on active surveillance. And we were able to show that, yes, indeed, it does predict. But the thing for this Decipher, so usually when you get a report, it gives you a score from 0 to 1. And the way it works is if you get a score between 0 to less than 0.4 or equal, then the patient deemed low risk for disease progression. And again, that's based on the data from the radical prostatectomy. If the score is 0.41 to less or equal to 0.6, then the patient is deemed intermediate risk. And again, if it is 0.61 to 1, it's a high risk. What we found is when we're trying to do this signature in the active surveillance, obviously the need is great to not just inform patient or physician about the risk of progression, but we also have to be able to say safely that maybe 95, 98% of the time, if we say that the test is negative, then the patient would not have any chance of getting adverse pathology on his radical prostatectomy. And what we found is to be able to have really significant, what we call it, negative predictive value. So to be able to say accurately that 98% of the times when we say that the test is positive or negative, then it's true negative and or true positive. Actually, it's a true negative for us. We had to lower the score on those tests to 0.26, which means if a patient's score is less than 0.26, we could say with 98% accuracy that the patient will not have adverse pathology if he had gone under radical prostatectomy. So you can see that because the change of the endpoint, the signature score may change from low to intermediate or whatever to be able to say yes or no. So this Decipher test is also not the only one on the market. There are a few other tests, but one of the issues with these tests is, first of all, there is usually some heterogeneity if you assess the signature on different cores, and also the cost of these tests. So the cost is about $3,000 or $4,000 US per test. And what we found is that even if you do the test, it will only be able to tell you that someone would have maybe like 50% chance of metastasis at 15 years or 90% chances metastasis at 10 years. But what we're trying to do is we want to develop a more clinical friendly test with lower cost, because we think the health authority, as you know, may not give approval to such tests because they're gonna say, okay, we're gonna pay $4,000 to have the test, but then the test is not able to say for sure that these patients do not need an active therapy, and they still need to be rebiopsied every year if they are on active surveillance, and that have higher risk of infections, hospitalizations, and bleeding. So what we're trying to do is we're trying to develop a simpler test where we can apply it in active surveillance population and potentially guide the urologist if the patients need to be having a repeat biopsy every year, maybe every 3 or maybe every 5, or maybe he needs to be actually on active therapy right away, depending on the genomic signatures that we can look at. So the easiest way as a pathologist is to utilize what we call immunohistochemistry-based signatures, because those are simple markers that you can stain the tissue samples in the lab and you can read it. And by looking at that, you'll be able to associate a certain expression of certain marker with either worse prognosis or better prognosis. So I'll give you a few examples, things that we are working on in the lab as of now. So initially we published on a 3 gene signature. We will use P10, which is a tumor suppressor gene. So usually if this gene is lost, the cancer is bad. Another gene is a transcription factor. It's an ERG. And in this notion, at least in publications, point that if you have overexpression of this gene, it's bad. I'll make that with reservations because I'm going to explain a little bit later. And then also another gene called CRSP3. Also, the high expression is bad. So when we combine all these markers, we were able to show that the signature is able to predict lethal disease in patients with prostate cancer, Gleason score 6 and 7. So this is the way we use immunohistochemistry. So it could be either red or brown or any color that you want. We apply it to the tissue sample and then you could assess it. So this would be significantly high expression of P10 gene, for example, and this would be a moderate or weak expression of P10. So this here on the right side, P10 is downregulated or low expressed, which is bad for the cancer. And this one is high expressed, which is good in the cancer because this gene is a tumor suppressor. And the beauty about these things is that you can actually combine more than one gene on the same sample. Because as you know, in active surveillance, these samples are usually small tumors, not that extent. So you want to maximize the number of genes you'll be able to read and use less tissue. So here, for example, P10 is red, ERG is brown. I have, working with another colleague in Michigan, we can have up to 4 markers in one sample. So you'll have one marker red, the other one is brown, and then you have a green and you have a blue. And you'll be able to look at different colors and assess the expression of different genes. And then we can have a combination of those genes and assess, depending on the different combinations, if deemed the risk is high or low for that specific tumor. So another marker that we were working on is called TFF3. And we also showed that this marker by itself is able to differentiate overall survival and cancer-specific mortality in prostate cancer. Then we combined it with, again, with P10, and we showed now if you have a 2 marker, then you have 4 groups. You have either 2 markers positive, 2 markers negative, or 1 marker positive and the other one is negative, or vice versa. And so you can see that the best group is actually if you have TFF3 positive and P10 positive. These patients have the best prognosis for overall survival and for cancer-specific mortality. And if you have both of them lost, you actually have a worse prognosis. Again, P10 is probably playing a major role now. We had about 4 or 5 publications, and you're going to see them now that all of them we are combining with P10 because P10 seems to be really bad actor if it's lost in the tumor sample. So we recently submitted a paper. We're looking at ATM gene, which is also a tumor suppressor. So if it is lost, it's bad. And now we're assessing it by immunohistochemistry. Again, we're showing that if you have negative or weak expression of this gene, you have higher chance of lower overall survival, and also you have higher chance of lethal disease. So now, again, we combine the ATM with P10. Again, you get 4 groups showing essentially, again, if you have P10 loss and ATM loss, then this is the worst combination as to the others. So with collaboration also with John Lewis in Edmonton, we looked at SRPK gene, and again, we showed that SRPK high expression is bad for both overall survival and cancer-specific mortality. And then again, we combined SRPK again with P10. Again, you can see that if you have SRPK high expression with P10 loss, you're at the worst prognosis as compared to having P10 normal and SRPK score of less than high. So this is essentially the chart that we're trying to assess and validate. So what we want to do, for example, if you biopsy someone and he has clinical or pathological criteria that fits active surveillance, currently Gleason score 3+3 or 3+4, maybe 3 or 4 positive core biopsies or maybe more, you want to have those patients on active surveillance. However, we're not able yet to say upfront how you're gonna follow up on these patients. Usually, currently, patients enrolled in active surveillance, then they get yearly biopsy, they get PSA withdrawn every year, and then they're gonna look at different things. And if they see that the biopsy Gleason score is changing, then they advocate the patient that he should not be on active surveillance and he should get treatment. What we want to do is have as much combination of these markers that I was showing you, essentially, for example, P10 ERG, maybe TFF3, maybe ATM or RPK, And then based on the combination of these, we'll be able to put the patients not necessarily in two groups, but maybe more. So you'd have very low, you'd have patients on high risk. So those ones, you either advocate that the patient should actually go on active therapy, or maybe potentially could be on active surveillance, but he should be biopsied yearly. If the markers are negative totally, then you can say that the patient safely can go on active surveillance, and maybe he would only need a biopsy repeated every 5 years. And if you have a combination of those signatures in the middle, maybe we will develop different protocols and say, okay, you'd be on active surveillance, but we would need to biopsy you every 2 years or every 3 years. So essentially making a grid for the different risk groups and be able to safely manage those patients, because we understand that these men on active surveillance, usually they have anxiety pertaining to, okay, am I okay if I keep my cancer within and I don't seek active treatment? Should I get active treatment? When you get active treatment, there are obviously side effects for the surgery, or even for the repeat biopsies, infection, bleeding, hospitalization. So we want to try and develop some of those signatures, which are easily to be interpretable by a pathologist, to be able to guide the urologist how often these patients should be biopsied. So we're looking at tissue-based signatures. We are also looking at blood signatures and urine signatures. And we currently have about 700 samples in the active surveillance program with Dr. Hyman. So we're looking at tissue, blood, and urine, again, to kind of guide or understand what signatures we can combine together to be able to inform in a better way how disease progress. And this is just one slide that I wanted to put in because I think Dorothy asked, some of you may have questions about the new treatment offered in Alberta. So it's called olaparib. It's HDDR mutation targeted drug. It's usually available based on the mutation analysis of the sample for patients with metastatic advanced castrate-resistant disease. If they are having either BRCA mutation or ATA mutations, they would be eligible to receive this drug, which targets the HDR mutations. I'm done. Thank you.
Excellent. On the VIP list, how do we get on that list?
Just let me know.
Perfect. Well, thank you so much, Rhett. I'm going to get you to open it up for questions. Always very informative. I think there may be a couple of questions regarding the last slide, those new treatments. The one question I had was, this is exciting information for men on active surveillance, and if we can reduce the number of biopsies that are required. How far away is this from reaching the clinics on a?
So obviously we have a lot of data about these genes now, where we're trying to understand the different combination. Once we know the combinations, which won't take that long to know, we need to actually start implementing on actual prospective basis. So now what we're gonna do, like a clinical trial. And so if someone comes and fit the active surveillance, we're gonna assess the biopsy with these markers. They're gonna probably still need to go in the same schedule of repeat biopsy, but at least we'll be able to, based on those markers, predict if he's gonna progress or not, and then see if our accuracy is correct between probably, I would say between 3 and 5 years, because that's usually when the patients progress. So I would imagine probably, are we looking at probably 5 to 6 years, take or give, to be able to say something with more definite.
Now, you had also mentioned that you had collaborated with Dr. Lewis in Edmonton. I know some of his work is moving towards, or some of his research is looking at liquid biopsies. Will that be combined with the type of work that you're doing?
Kind of. I think he is looking at a diagnostic test. So basically, as you know, a PSA is not sensitive for, or sorry, is sensitive for prostate disease, but it's not specific for prostate cancer. So I think what he's trying to do is develop a diagnostic test to tell if the patient have a prostate cancer or not from blood sample. We're trying to focus more on prediction and prognosis in the way of, are we able to tell which cancers are bad, which cancers are not bad, and so how can you make the treatment decisions more accurate. So we're looking at those tissue. We also have a blood that we looked at the germline mutations, and we're looking at urine. We have, so my research kind of focus on two things. One is the active surveillance, and the other one is what we call neuroendocrine prostate cancer, because currently with the introduction of all the newer anti-hormonal therapy like abiraterone, enzalutamide, all of these things, what we're finding is now you have up to 30% of tumors, actually, if you give them hormonal therapy or radiotherapy, they, for some reason, de-differentiate and become neuroendocrine. And when they become neuroendocrine, these tumors progress significantly faster than a regular adenocarcinoma. And so you can see that you're hoping to treat a patient by give them hormonal therapy, but this hormone acts in a bad way and causes the cancer to just accelerate and de-differentiate. So trying to understand, again, what would be the molecular alteration or background of these tumors that predispose them to this high-grade neuroendocrine differentiation if they've been treated with hormonal therapy. And I'm working with a oncologist, the Tom Baker, Stephen Yap, to understand these molecular features and how the hormonal therapy could actually change the genomic environment of these tumors.
Wow, exciting stuff. I don't know, Rhett, if you had any chat questions, but I'll open it up for the room. If anybody has a question, just raise your hand. We'll get you unmuted and we can carry on the discussion. Stuart, I was going to say, I can't believe Stuart didn't have a question. Just unmute yourself, Stuart.
There we are. Yeah. This is excellent progress. Nice to see, Tarek.
You too.
I'd like to have you speculate on one of the slides that sort of is your summary slide, and take that in time earlier in the diagnostic pathway, because all of the gentlemen that you've got samples from, I think, will have been referred to the Prostate Cancer Center through a family physician. And I'm keenly interested in having tests that have great utility earlier in the cycle for early detection of prostate cancer? The risk, not detection of prostate cancer, but an assessment of the risk.
You mean the risk of someone to develop prostate cancer?
There you go.
Okay.
So
So yeah, so it's not going to be these tests, but we're working with my colleague at UCLA, and he's looking at genomic signatures in the blood
yes,
to try and predict which patient or which men actually gonna develop prostate cancer and over how long of time. So he actually presented some data about 3 weeks ago at University of Calgary, showing his work in progress to develop this. I think there would be some, so potentially now, for example, we have some hints that if you have if a tumor or if a person have a BRCA mutation or ATM mutation in their germline, which means in their blood sample, they are at higher risk of developing prostate cancer over time. The risk probably about maybe 3 or 4 times if you don't have the mutation. And he's trying to add in more signatures or more genetic information to try and predict early on and maybe during infancy. So if you have these markers, what's your probability of developing prostate cancer?
understood. Now, I'd like you to take that same scene and move it beyond the initial treatment, the initial therapy, and look at recurrent disease. And do you think there's potential to assess risk of recurrent disease?
Yes, so those would be similar to what I just presented. So because this would tell you that, well, kind of. So this would tell you that the disease is gonna progress, and eventually those that are progress, they're gonna have metastasis and they're gonna recur. Same notion, we find, for example, those what we call DDR mutations, which are the DNA repair pathway genes defects, like BRCA and ATM and CDK12. Those are the ones have higher risk of metastasis and higher risk of recurrence. And it seems also that if you target those with these newer drugs, they slow the progression or treat the metastasis in a more significant way compared to chemotherapy, for example. Bear in mind that we also have what we found recently is in prostate cancer, there is a subtype of prostate cancer. It's called ductal carcinoma or intraductal carcinoma. So these are rare tumors. So only like 1 or 1.5% of all prostate cancers will actually be ductal type. But if you look at the rate or the incidence of these mutations, if you look at it in adenocarcinoma, in advanced metastatic adenocarcinoma, for example, it's about 20%, 25%. If you look at it in ductal carcinoma, it's about 50%.
Oh boy.
So it seems now that we are slowly trying to maybe associate certain morphologies with genomic mutations and the risk of metastasis and recurrence, but we also having assessment of these mutations if they are not only detected in the tumor, but are detected in other cells within the patient, and they have a higher risk of developing prostate cancer. And what we're finding now is actually those same DNA repair pathway mutations, they have predispose the patients to higher risk of prostate cancer, but also in the women, they predispose them to breast cancer, ovarian cancer, and all of the so they are mostly connected. And we actually trying to develop a platform for genomically testing all men with advanced prostate cancer, and also all women with advanced breast cancer in Alberta, to offer them the genomic testing.
Thank you.
Thanks.
What a quiet group tonight. Any other questions? Oh, Bob Phillips. So Bob, just unmute yourself. Rhett had to step away, so.
Okay, I'm unmuted. Very interesting. I'm learning a lot from you tonight. Thank you very much for your presentation.
Thank you.
I just want to pose a question about myself, and my last 3 PSA tests have been steadily increasing. About 3 PSA tests ago, I was at about 0.1, and then the one after that, it was 1.1, and then the one after the most recent one is 2.1. What kind of trend is that?
So over what, like over a year, like between each test is a year?
No, that's in the last 6 months.
So from 1.2 to, sorry, from the
Point-
last one is 1.
Yeah. It progressed at one at a time, actually, 0.1.
Yeah, so it's
then-
more than, so it's about doubled within 6 months.
Yes.
Yeah, I mean, it is worrisome. So if I may ask, so you had what, like had a radical prostatectomy before?
Yeah, robotic surgery, removal of the tumor.
Okay, and do you know what was the stage for that?
Well, the surgeon, his name was Dr. Kawakami at Rocky View. He said it was about 70% tumor of the prostate.
Okay, and what grade is it? 3, 4, 4, 3? Do you know?
I think it was 3.
Okay, 3 plus 3.
Yes,
Okay.
yes.
Yeah, so 3 plus 3 usually, yeah, they don't progress as much. But again, we don't fully understand the molecular of these, because we're trying to pick up the small number. So like if you have 100 men with 3 plus 3, maybe 3 or 4 of those would actually progress and the others won't, for a period of like 15 years or so. Given the rate of PSA speed in doubling, this is worrisome. So I think they would probably need to check if there's like maybe a bone scan or something, and see if there's any evidence of metastasis, for example, or anything. And then if God forbid, if there is something like that or whatever, potentially either start early hormonal therapy, or they would need to do some additional testing if possible, just to see if there's any mutations in these tumors.
Okay, thank you.
In the various gene signatures that you've worked on and have seen some evidence of recurrence, is there an indication that particular signatures may lead towards a particular type of metastasis, or spreading from the prostate gland through the lymph node system into the bone or
Well,
soft organs? I'm just thinking about your P10
yeah.
in
So
particular.
Yeah, not necessarily going to like whether the tumor is going to go to bone versus other organs.
Yeah.
But what we're finding is like, especially with P10, the risk of lethal disease is high and overall survival is decreased. So in the last paper where we had P10 combined with ATM, if you actually have if you are in the high risk for P10 and ATM, if a patient is in the high risk of P10 and ATM, the risk of overall survival is decreased by about 4 years, and the risk of lethal disease is increased by about 3 years, like the difference.
Mm.
And then the fold is about 3 folds or something. But if you look at the mean length of time between the sample taken out and the last day of follow-up for those patients, if they have the bad signature for those 2 genes, it's shaving about 3 to 4 years of overall survival or cancer-specific mortality.
Thank you.
Now, if I understood you correctly, there's no clinical trials started yet?
Not on those, no. But this is
No.
what we're trying to do, because
Yeah.
now we have some good thoughts about the combinations that we're gonna add in. So it's just a matter of trying to figure out how we're gonna implement these trials going forward.
Yeah. Exciting stuff.
Yep. Thank you.
And would impact many of the group, both those on active surveillance as well as those with recurrent disease.
Yeah, I think so. I started so I came to Calgary in 2008. So it's now 12 years, and I would say that this year we just started actually having a good team of researchers. So you have Eric Hyman, Jeff Gatto in neurology. You have Stephen Yep in medical oncology. We have a molecular pathologist in Edmonton, and we have a basic scientist, Susan Miller, also in University of Calgary. So we kind of now have a team. And then my collaborator in UCLA is really known for his computational-based signatures and discovery. So we are now having ability to test different platforms, and we sent the samples to UCLA. I have a meeting with another group in Toronto to actually gonna send them the urine samples of those active surveillance for them to look at the signatures in the urine. So I think we probably, I would say in 2 to 3 years, we should have something narrowed down to be able to test it prospectively.
That's excellent.
Now, do you feel what, in your opinion, would the impact of the advancements in technology, have they accelerated the research significantly?
I think so. There has been some very good understanding now of the risk of specific mutations in the germline for prostate cancer, like in the BRCA, in the ATM, in the CDK, and there is more awareness about them now that currently they will offer genomic testing for any man who have advanced castrate-resistant disease. They would offer them genomic testing because they know that there is an available drug that is good for targeting these mutations, and also to understand and educate the risk of the family of those patients that they potentially could have higher risk for prostate and also for breast or ovarian cancer.
But that testing's not available in Alberta as of yet?
It is available through a clinical trial.
Okay.
And we just submitted a grant with Dr. Yap to the University Hospital Foundation in Edmonton. And we have funding to test. So we're doing a study, actually, we're testing with fund from AstraZeneca because they have the drug. So the testing is available. And if anybody meets the criteria of having advanced castrate-resistant disease, they could talk to their urologist about the testing, and they should refer them to Stephen Yap, and we'll get the tissue samples pulled out and tested.
Yeah, I had been on the Alberta Cancer Foundation trial study website a week ago, and I didn't see any mention.
No, this is not yet in the Alberta kind of system. Like,
yeah,
but we are able. So what we're doing now, we're collecting all these samples and we're testing them because we have the funding to test them. And then I think the drug is available. If the patients have these mutations, the drug is available based on the recommendation from the oncologist. Like, the company is able to provide the drug.
And this is a drug called olaparib, is that correct?
Yes.
Okay, thank you.
Yeah.
It's a PARP inhibitor.
Yeah.
So there is like different classes. There are actually 3 or 4 companies who make similar drugs.
Yes.
But it's under the umbrella of PARP inhibitor drugs.
So best to talk to the oncologist.
Exactly.
Perfect. Good information. Thanks for sharing.
You're welcome.
All right.
The question for Tarek.
Sure.
Yes.
To what extent, Tarek, is research funding, the availability or the lack thereof, holding you back?
Actually, it's a good question. I was about to close my lab in 2018, and I was gonna close it in December because I ran out of funding and I wasn't able to continue. And then we got actually a team grant from Prostate Cancer Canada just that time. It's a 1.5 million funding for 4 years. So my collaborator, actually, the one in the bioinformatician who is now in UCLA, was in Ontario. So we were able to get that funding to start investigating the signatures in the active surveillance population. So as of now, I think I'm done in terms of I'm stable for my lab for the next probably 3 years. I probably didn't spend as much because of the COVID situation. We had to close the lab last year. So we actually still have quite good chunk of the funding. And we're hoping that we can talk to Prostate Cancer Canada and tell them that they should give us an extension and not to ask us to return the money, so we'll be able to actually carry out the project.
Another casualty of COVID.
Yes. Actually, there was some research done early on from Europe, from Italy, and from the United States, showing that there is some association between the hormonal therapy and the risk of having severe COVID, because the androgen blockade seems to block a gene that is required to transport the virus into the lung. So actually, men with prostate cancer on hormonal therapy have less chance of catching COVID and less aggressive COVID.
I guess if you're looking for the silver lining, that could be it.
Yeah, but there is a lot of research. They try to obviously understand how this would work and if they would be able to potentially use some of these therapies to prevent COVID or progression or disease. So I think, unfortunately, we're still probably several months away from clearing this out, and with the emergence of the new variants or whatever, we need to be extra careful to mitigate this thing until we see what happens.
I don't disagree. We've got lots of time to practice our Zoom presentation skills, that's for sure. So good.
Tarek, you're saying your funding is pretty much set for the next 3 or so years. If that's the case, does that mean that most of your time then is spent on research as opposed to writing up grant proposals? And when that funding runs out, what percentage of your time is going to be spent writing grant proposals versus research?
So the fortunate thing is that I have 50%. So 50% of my time is protected for academic. So I do 50% reading slides, but then 50% of the time I do for my research, and that is mixture between writing grants, writing papers, or apply for funding. So currently I'm applying for one more grant probably in, I think it's due in April, but just for the fun of it. We're stable in terms of funding for the next 3 to 5 years. So I'll be able to concentrate more on the research. And because of the funding, we're able to get more fellows into the lab to actually progress. The issue was that, so we were doing very good progress up to March of last year. And then the progress was very slow, almost to a halt, because I had to close the lab. There's nobody to process the samples. And so we had delay to be able to utilize any of those samples to actually investigate the signatures. Now we're just starting to do that. So I'm hoping that we can kind of convince the funding agency that we need more time to be able to get to our data, because now I think also you probably know that Prostate Cancer Canada has amalgamated with the with the Canadian Cancer Society. So they are both one entity now. So we have to work with them to try to do that. But actually, what was good is that initially when they gave us the funding, they gave us only for 2 years. So we had asked for 1.5 million. They gave us 900,000 for the first 2 years. Then they did we did actually 2 fundraising in Calgary. So I went to the, what's it called? Brookfield Tower?
Yeah, to the Step Up Challenge. We
Yes.
participated in that the last couple of years.
Yep. So they did the fundraising and they came through with the remaining of the funding for the 3 years, and they extended it for 1 year. But because of the COVID, now we shaved about a year and a half, or almost, yeah, it's gonna be probably a year and a half, because we don't anticipate things to go back to normal until probably September. But we hope to be able to accelerate the progression and move forward faster.
Tarek, with the amalgamation of the Prostate Cancer Canada and the Canadian Cancer Society, does that mean there's a dilution in terms of the, shall we say, the prominence of funds for prostate cancer research?
Not that much because, well, I mean, it depends. Sometimes what they do is they open funding opportunities, and then they have within the funding opportunity specific targeted area where they say, if you're studying this, they have extra funds available for this specific disease or something. I didn't see that yet in the Cancer Society yet, because I think the funding opportunity is gonna come up in April, but the Cancer Research Society in, sorry, the Canadian, what is it called? The one in Quebec, the Cancer Research Society in Quebec, within their funding call, this time they said if you're studying genomic, prostate cancer, or breast cancer, they have kind of allocated additional funds as a targeted thing. So what we're doing, or what we're trying to do now, is because we know that these mutations affect both breast and prostate cancer risk. So I actually reached out to other investigators that they're working on breast cancer, and we asked them if we can use some of their samples to test the genes that we are identifying in prostate. And we also have a basic scientist who will help us out to look at cell lines in prostate and breast. So we hopefully be able to use that additional opportunities to investigate those further.
Thank you.
Thank you.
All quiet. Good. Well, again, Dr. Bismar, on behalf of Prostate Calgary, I want to thank you for your time this evening. It never ceases to amaze me how much I can learn in an hour when you're talking. I'm looking forward to further developments as a result of your research. I think this is exciting for our members to hear of the work that you're doing. I want to thank everybody again for coming out on a frosty night.
Thank you, Brad, again for this lovely evening, and thank you all for attending and asking questions, and hopefully we'll see each other soon.
I hope so. So everyone, I want you to stay safe, stay healthy, look after one another, and don't forget it's Valentine's Day coming up. So have a happy Valentine's Day. At the end of the first period, it's still 0-0. So we have time to catch the next two periods. So we weren't battling the weather or the flames tonight. So it all worked out good, Tarek.
All right.
Good.
Okay.
Thanks for
All
putting
right.
this together.
Thank you, Tarek. Thank you, Brad. Thank you, Rick.
Good
Bye-bye.
night, everyone.
Good night.
Yeah.